Hello, everyone. My name is Noemi Spinazzi. Should I get started on the presentation or wait?
I think you can go ahead and get started if you want to share your slides.
I'm going to do just that.
Okay.
Can you see it as presentation mode right now?
Yes, we can.
Excellent. Hello, everybody. My name is Noemi Spinazzi. I am a physician at UCSF Benioff Children's Hospital, Oakland, and I am the medical director of the Down Syndrome Clinic there. I am here today to talk to you about transition to adulthood, a pediatrician's perspective. I don't have any relevant disclosures for today's talk. I do not make any money from this, which is quite all right with me. I have a lot of goals for today. We're going to review some key aspects of transition to adult care. We're going to identify ways in which your pediatrician or physician can support someone with an intellectual or developmental disability in the process of transition. This applies to individuals who do not have an intellectual or developmental disability, as well as kids who have medical complexity without a developmental disability. We're going to think about different options for supported decision-making for individuals with IDD, and we're going to review some resources that are available. What this talk is not, it is not a silver bullet to solve all issues related to transition. I do not have a list of amazing adult care providers that are just the people to go to. I wish I had that. I've been trying for a very long time to develop such a list, but that is not what we'll talk about. I want to ground this talk in the context of ableism, which is discrimination and social justice, social prejudice against people with disabilities based on the belief that typical abilities are superior. It's rooted in the assumption that people with disabilities require some degree of fixing and that they're defined by their disability. And it is harmful. And I want to acknowledge as a physician that my medical education was rooted in ableism. I know that this is a mixed audience, and some of you are family members and individuals with a disability, while others are professionals. And I think it's very important to recognize that all of us carry ableist biases and to be quite wary of our implicit biases as we talk about many of the concepts that we'll discuss today. When we talk about transition to adult care in the United States, we're talking about something that happens to a lot of people every year. There is an estimated 750,000 youth with specialized healthcare needs who enter adulthood each year in the United States, and more than a third have either a developmental disability and a behavioral or emotional condition or neurodevelopmental conditions such as autism, ADHD. There are a lot of issues that are related to transition, what we familiar refer to as the cliff in common parlance, including medical care, primary as well as subspecialty care, and the coordination of all that care, post-secondary education, employment, legal decision making, social inclusion, behavior support, ongoing acquisition of skills. We are all learning all the time throughout our life, self-advocacy, and then caregiver support and wellness as well. What are some barriers that families and caregivers and healthcare providers face? There's very limited training on this topic for all of us who work in healthcare. There's also no transition specialist. You know, I can send someone to ear, nose, and throat so easily, but I can't send them to the transition person who's going to think about all of the transition topics. There's financial barriers, and there's the catch-22 of disability services, where as soon as you start saving even a little bit, boom, you're no longer eligible for those services. Although I know that discussions around amazing programs like the Cal Able accounts are part of today's this event. There's not enough time. I have 15 minutes with a patient. That isn't possible to give justice to the topic of transition in such a small amount of time. I would add that for financial barriers, maybe you'd say, well, why don't you hire a transition specialist? And then there's all kinds of barriers around how do we financially support someone who can be an expert in that field. It's anxiety provoking. I know that when I think about planning for stuff for the future, even something as little as going on a trip, I feel anxious, let alone something as big as a whole transition to a whole different set of systems, right? That is so anxiety provoking that for some, that very helpful mechanism of let me not think about it right now can lead to delays in talking about transition. There's not a lot of developmentally appropriate tools to assess readiness for transition. As I mentioned in one of the earlier slides, it's not like there's a line out the door of adult providers who have expertise in complex developmental and medical conditions and are just eager to take on patients with medical or developmental complexity. And we're not reimbursed adequately for this work, and there's not enough people to do it. And the system is so confusing. But we're not here to just talk about barriers. I just want to name them because we would all be doing a much better job if there were no barriers in our path, right? There's some literature on the topic of transition to adult care. And not surprisingly, it says that a few youth with specialized healthcare needs are receiving adequate transition preparation. And like everything else in healthcare, this is worse for racial and ethnic minorities. And young adults, including those with specialized healthcare needs, have poorer access to care than younger children. Once again, this is more so for those who are racial and ethnic minorities, and ever more for families that are experiencing social drivers of health, such as inadequate income. What I want to press upon you, even more than all the barriers and obstacles that are in our place, is that when we're talking about transition, we're talking about a journey, not a one-time event. And so what you'll hear me say over and over in today's talk is that we have to think about it as a walk that we take together starting early. I started earlier than parents have often begun to think about it. Maybe I'm talking about it when someone is 12, and it throws parents for a loop, but I'd rather think of this as a journey that we're walking together for many years, so that we have ample time to think deeply about many of the topics that we'll talk about today. Some aspects of transition will be very practical. Let's find you new providers. Others will be exploratory. What are you into? What do you like? What might be something that you do for the future? And how can you be more independent? And as I've mentioned, this requires multiple conversations and can be a long and winding road that starts and stops. My organization, the American Academy of Pediatrics, has a transition algorithm and recommendation, and it turns out it does recommend starting this conversation as early as 12 years old, and to amp up the frequency and the intensity of these conversations as we get closer to transition. It is worth noting that based on what we know in the literature, caregivers may be less likely to even begin to think about their young person as an adult when that person has a more significant developmental disability, and the greater child's need is for assistance is associated with this is in research. I'm not talking about individual people, of course. You're all here to learn more, so you're all here already thinking about transition. But that greater need for assistance and care was associated with lower parental expectation that their child would live independently, as well as the presence of behavioral issues that was associated with lower expectations that their young person would one day live independently. So again, this is an area for thinking together and trying to problem solve from early on. I want to say that for us healthcare providers and service providers, it is very important to be very respectful of the patients and the family's goals. What are the goals of the individual with a medical or developmental disability? What are their aspirations? Many of my patients tell me that they want to live on their own, be married, have a job, have kids, be independent. And we really have to listen to our loved ones and think together about how to meet those goals. But also, what are the family's goals? And really then serving as an ally as well as a mediator to try to get those goals and priorities aligned. So as we talk about different topics of transitions, what you'll notice is that I'm just going to ask a lot of questions. And these are a lot of questions that we can ask ourselves, that we can ask ourselves as caregivers of our loved one, that we can ask ourselves, that we can ask our patients and caregivers as service providers to support the transition. So the first part I want to think about together is taking care of one's health. So starting with interactions with healthcare providers, what kind of assistance does a young adult need when they see a doctor? Is it a trusted person to be there with them to provide additional information and take notes? Is it an augmentative communication device? Is it extra time? Is it information modified to be more accessible? Have they talked to their doctor one-on-one ever? I think that um, all of us pediatricians, me included, have differences in how often we talk to a young person with a developmental disability one-on-one versus someone without a developmental disability. And one-on-one sometimes should be without the caregiver and sometimes should be with the caregiver, but we all have a tendency to hone in on talking to a caregiver because we got 15 minutes and we got to get a history and there's a lot to talk about, and neglect to turn to the actual patient and ask them the question and talk directly with them. And how do we expect a young person to learn how to talk directly with their doctor if their doctor is never talking to them directly, right? As a parent or caregiver, am I answering all the questions? Are there opportunities for me turning to my young person and having them answer some of the questions? How do they communicate about things like pain, discomfort, symptoms in general? What is the most effective communication method that they could access? And are we getting to practice talking about health and health symptoms with that communication device? That might be partnership with the school and the IEP and the AAC specialist to ensure that language around health and health symptoms is included in a device, for example. Does the young person know when we call the doctor in the first place or the dentist? And would they know what to do if they feel sick but the doctor's office is closed? If the answer to that is no, then fine. This is an opportunity for direct instruction in these areas. Some people have chronic medical conditions. Do they know what medicines they take? Do they know why they take these medicines? And it doesn't necessarily have to be a memory test. Is it, I know that in my wallet, I have a little card that has my medications. And if someone asks me what medications that I take, I can pull out my card and show it to the doctor. Are they becoming more independent with taking their medication? This might be taking them out of a pill box and having reminders. Again, it doesn't necessarily have to be, I remember in my own head that every morning at 9, I open the pill box and I take 1.5 tablets. If we're putting the medicines in the pill box every week together, and then I'm the one opening the pill box and taking them, even with a caregiver supervising and ensuring that it's done correctly, that is just more independent, right? Do they know if they have allergies to foods or medications? Food allergies and medication allergies are life-threatening conditions. It is very important to know what our allergies are, or to know that we carry a bracelet that lists our allergies or a card in our wallet that lists our allergies. How do we know when it's time for a refill? You know, is it that we decide that when there's 5 pills left in the bottle, that means refill, and then we name that and we model, oh, there's 5 tablets left. What does that mean? It's time to call the doctor to ask for a refill. It's time to call the pharmacy to see if we have a refill. There are some transition worksheets that are published by Children's Hospital of Philadelphia that can assist caregivers and educators in supporting a young person in working through some of these topics. In all of these slides, you see QR codes, and the QR codes take you directly to places online where you can download these resources and worksheets. Alameda County CCS has made their own worksheets, and I love them because they have them in Spanish as well. They're similar to the ones from CHOP, and again, they're helpful in assessing where am I, where is my loved one in terms of there's healthcare as it pertains to health, and if we're in the my child does not know yet, then should that be something that we're actively working on together? I see that perhaps an interpreter has joined, so I'm wondering if I should take a little break to make sure that our interpreter gets caught up.
Yeah, give us 1 second. Thank you, Noemi.
Okay, I do see that the interpreter is on mute and talking, so I'm gonna give you a second to make sure we're all set up with the interpreter.
Adriana, do you want to try to speak and see if your audio works?
Yeah. Okay, well, I can just transfer you there again. I haven't had a chance to check.
I can't hear anything.
Just transfer you.
Yeah, we do not hear you, Adriana.
Yeah, sure.
Adriana, can you switch to the Spanish channel? There you go. Okay, we're all set. I'll put some instructions in the chat.
Awesome. So, si ustedes hablan español, ahorita tenemos a un intérprete. Instrucciones estarán en la función de chat para ver cómo conectarse con el intérprete. If you speak Spanish, I just told you to look at the chat to make sure you're connected to the interpreter. Continuing with the topic of taking care of one's health, nutrition and exercise are cornerstone of good health. So in thinking about how a young person is taking care of their health in terms of nutrition and exercise, do they know how are they doing with choosing healthier drink and food options? How are they doing with portion control? What are their diet and exercise habits? Do they need visual reminders of portion control or schedules for exercise? Can they cook for themselves? And what things can they cook for themselves? Sometimes the easiest meals to cook are also not the healthiest ones. I want to call out the Chicago Adult Down Syndrome Clinic. They have an incredible program of video modeling. All the actors have Down syndrome, and they have videos on fruits and veggies, grains, protein, dairy, portion control, what to do at a buffet, how to stay hydrated. I think they're pretty neat, and sometimes it's fun to hear this advice from other people who have a disability. Another very important aspect of transition is reproductive health. a moment where it's good to analyze our own biases, especially as healthcare providers. We may have our own thoughts and beliefs about reproductive health and sexual health. But when it comes to taking care of young people, it's really important to set those biases aside and provide equitable reproductive and sexual health care to everybody, regardless of disability. It might start with hygiene. How much support does a young man or woman need with their hygiene needs? Is this because we're in a little bit of a habit of continuing to help with showering or wiping? And could the young person become much more independent with these activities so that they don't require adult support and therefore be desensitized to an adult being all up in their business when they're undressed? A young woman, does she know how to track her periods? Periods being regular and not too heavy is a really important part of a woman's healthcare, right? But it starts with knowing when your last period was and if they're regular and how often we change our pad and all of these topics. Does a young woman know how to check her breast for lumps or bumps? What about a young man for testicles for lumps or bumps? Is that something that we are teaching in our exams just like we do for neurotypical peers? Is that something that requires caregiver support? And in that case, how do we make it so that it's clear that we are providing a medical procedure or an appropriate support as opposed to, once again, someone just randomly palpating a testicle or a breast, which is not the kind of messaging that we want to send. Who is a safe person to talk to when it comes to issues related to genitals or breasts? We have to really stay away from the messaging that penises and testicles and breasts and vaginas are taboo and we can never speak of them and we can never think of them, right? Because then people are not going to tell us if they have a painful testicle that could maybe be a testicular torsion, right? Instead, we have to reframe it as these are topics that are private and there are safe people that it's appropriate to talk about these issues with. And if you feel pain in any of these areas, it is really important to speak up about it. And let's remember, sexual health is health. Has the young adult received any type of sexual education through school or other means? I was in an IEP yesterday that was, I hated it. It was discussing the sexual behavior of this really young child who had touch some private parts inappropriately. And the kid was starting to go through puberty. And I had to step in and say, first of all, let's reframe the words that we're using, but also what kind of sex ed curriculum do you have? And they were like, we don't have any. And I'm like, well, how is this young person ever supposed to learn about puberty topics if they're not taught? And are you surprised that this person is exploring private parts and their rules and what they mean if nobody's teaching them about them? Do we understand the concept of private versus public? And I have a whole other talk on this topic, but private can be a loose term because a bathroom is private, but is a public bathroom private? And is it as private as a personal bathroom in someone's home? A bedroom can be private, but if I share my bedroom with my 3 siblings, then it's not so private. So there's some nuance in this. Does the young adult understand the concept of consent? Are they ever allowed to say no? Unfortunately, individuals with developmental disabilities have learned compliance. And I always see topics in IEP, goals in IEPs around compliance, and I don't often see goals around the opportunity to say no. And so how do we expect someone to then be able to say no vehemently if someone is relating to them inappropriately? So I actually have a philosophy that I ask everybody before I check the private parts, and then I model that for other parts of the body, like the ears and the mouth. And if someone says no, my answer is, this is your body and you decide whether this part is checked or not. You have agency over your body. If it is an area of direct concern, that I will let them know ahead of time. It is very important for me to check this private part today. I understand that it might be hard. I am a doctor. This is why I'm doing it. But then I don't ask them, is it okay or not? Because then if they say no, then I'm going to find myself in a position to have to override their no. And that is not the message that I want to give. Have we talked about crushes? Have we talked about relationships? Have we talked about sex? What does sex mean for that young person? I remember another situation where everybody was really freaking out because their young person had had sex with his girlfriend in the bathroom, and everybody was in the school bathroom, and everybody was freaking out. And I asked him, what does it mean to have sex? It turned out they had hugged really hard. Like, okay, well, having sex like that is not appropriate in the public bathroom. Um, let's define sex a little bit more so that we can determine what size reaction we're going to have based on different concerns. And as we gear up towards transition, we might want to make a to-do list. What specialist does my child see? And let's make a plan for transitioning them. Maybe let's not have like 5 new doctors all at once. What's a specialty that it's in a pretty solid place where we're just going maybe once a year just to make sure everything is okay? Can we transition that one first? What about a new problem? Maybe I'm 19 and I have a new ankle injury, and usually I'd go to Children's Hospital for physical therapy, but can I go and see the adult doctor, the adult physical therapist? Why not try an adult provider with a new issue for a new issue, since I don't have an existing relationship with a pediatric provider? The second point is particularly important for individuals who are really close to transition. What medications does my kid take, and who prescribes them? And do we have enough supply to get through the transition? And has a pediatric healthcare provider made themselves available to provide additional refills if there's any hiccup in the transition process? We cannot have kids who take medication chronically suddenly go without their medication, right? What therapies do they receive and need? Which ones are going to be able to be continued after the transition? For example, behavioral health services like ABA are a benefit under Medi-Cal until 21. And then what happens? And then who's going to pick it up if this is something that for which there's ongoing need? How do they get to appointments right now? And what will that look like when they transition to adulthood, especially if they're living on their own? Are they prepared for a health emergency? Do they have a medical ID bracelet or other device? We have cool stuff on our phones these days. And is it easily accessible? And then I often have to be the person asking the difficult question of caregivers of, I know you know your loved one best. And what happens if you get sick? We all get sick sometimes. Sometimes accidents happen and we might be incapacitated for a brief period of time. What's the plan? Is there something written down of what works for your kid and what is needed for your kid? And is this information easily available to a family member were you to be sick and not available to provide that level of care? There's more worksheets that have to do with the healthcare plan and medical care and emergency and safety that are also available through CHOP. And I had put the QR code in the earlier slide. And as I've mentioned, I don't have a list of the most amazing adult doctors in the world. So I like to remind people that they're not getting married to this adult doctor. They're just starting with someone. And, uh, and, uh, and so it might be that the first adult doctor you meet is the perfect one. And it might be that it's not the right fit and that you might have to look for a different provider who fits your needs better. We're just getting started. We're just starting with one person. But in looking for that person, I think it's kind of important to think about what is it that makes my pediatric provider so awesome? Is it that they take the right amount of time with me? Is it that they talk directly to my young person instead of only talking to me? It's that they're easily accessible. It's that they have same day appointments. It's that they have behavioral health integration in their office. Whatever it is that makes it work right now, let's look for those things in the adult provider. If any of you in the audience are yourself pediatric providers, my greatest recommendation is for your last note to be a really thorough and complete note. Nobody has time to read a full medical record. Nobody. And so if you expect someone to request the giant chart from the children's hospital and read it to get to know the person you're transitioning, then you're setting someone up for not ever having done that. So I take extra care to make that last transition note a very thorough note. It might have the specialists and therapists involved in care, including name, institution, last appointment date, a current functional and neurologic status, so that if there's a change, it can be easily recognized. If there's formal testing that describes current cognitive status, that would be awesome to include as well. If there is condition-specific emergency treatment for metabolic conditions, diabetes, whatever, that should be in the note as well. The young person's understanding of their own health conditions, how they communicate, how independent they are with different things, ideally will be in the note as well. And then it's really important to put DME information as well, because whether it's continence supplies or orthopedic supplies or whatever, those needs will continue once the person transitions away from your care. And if the wheelchair breaks, so the new person is going to have to know how to direct the family. It's also important to know what decision-making arrangements are in place. And I'll talk about that in a little bit, as well as communication preferences, whether it's an ASL interpreter or an augmentative communication device. So speaking of making decisions, one of the questions that we ask ourselves is, does the young person have the capacity to make their own healthcare decisions on their own and or with a trusted adult? And does the parent have the legal standing to continue to assist their child with decision making once they become adult? And what are options available for these young adults? And is there a difference of opinion between parents? Are there custody battles or other special circumstances that we should be paying attention to? Some principles, core principles that I live by. One is self-determination, the right of a person to participate in their own decision-making. 2, dignity of risk. Sometime when you have like 5 or 6 hours, spend some time with me so I can tell you all of the mistakes that I got to make. And some of them were really hard to make. I've lost money, I've gotten divorced, like I have all kinds of mistakes to tell you about. And you know what? I got the chance to make those mistakes. And sometimes we love our people with developmental disabilities so much that we feel like we have to protect them against every possible risk or mistake. And I just want to challenge that notion. Certainly, there might be some decisions that carry some greater inherent risk where we might want to be more closely involved. But also, can we get a chance to make a bad decision here and there? And then again, bias check as a provider, how do I feel about that and how might it impact my own counseling? And a lot of what I have to do is my own bias checks and my own therapy to grow in this space. So California is a good place to be, and I know that a lot of the Family Voices Summit is centered around these topics, so I don't necessarily have to go into tremendous detail about legal decision making, but I want to call out that effective January 1st, 2023, there is law in California that formalizes supported decision making to hopefully reduce the number of individuals who otherwise would have had their rights removed through conservatorship. And the idea is that the capacity of the person for decision making is assessed as their own capacity plus the support person that is helping them. And with that setup, then most people with a developmental disability have the capacity to make decisions. And again, I want to name, like, how do you make decisions? I know that when I have to make a really difficult decision, I consult my friends, I consult my parents, I consult my husband, I consult my therapist, my colleagues. We all have supportive decision-making arrangements in our own lives. So this shouldn't be such a foreign concept. A supportive decision-making agreement is a private agreement that includes which areas a decision maker wants support in, who is chosen to provide that support, what kind of support is desired, how the agreement is written and executed, and when the agreement needs to be reviewed and when it terminates. So when can it be revoked? So all of these are important parts of a supported decision-making agreement. It does not have to be in writing, although it does help that it be in writing, just because as we deal with different institutions, sometimes barriers can be put in place, especially if something is not written down. I like power of attorneys. They're legal documents witnessed by a couple of unrelated individuals or a notary public that outline who can help us make decisions. The individual retains their legal decision-making abilities, but specifically calls out one or more people who can formally and legally support that person. I have a medical power of attorney, and my husband is named as that person, as well as a financial power of attorney, and my husband is named as that person. So again, this is not such a foreign concept. The person with a developmental disability needs to have the capacity to understand and sign a power of attorney, but this can be done with support, modifications, explanations, right? So it doesn't have to be, you can read a super long and wordy legalese document. It's that you understand that you are signing a document that says that your parent can formally sign documents for you and can formally advise you on decisions that have to do with your health. And it's not up to the notary public to decide capacity. So I've heard of some families going to the notary and then being told that the person didn't have the capacity to sign, but that's actually not the notary's job. Thank you very much. And someone can have both a shared decision-making agreement as well as a power of attorney. Conservatorships are legal processes whereby an individual is deemed to lack capacity to make their own decision. The court takes that person's civil rights, individual rights for legal decision making, and lends them to designated people, often it's parents and siblings, but then the court also retains the ability to take them away and give them to whoever else. And unfortunately, there are many situations in which something like that can happen. And then while we might feel that we as parents and caregivers have the person's best interest at heart, it might not always be the case when it's someone who doesn't know the person at all. This is not meant to scare people who already have conservatorships. I think that before last year, it was really the default for families to be able to continue to support their loved ones. And unfortunately, it's something that was also continues to be highly encouraged. But I'd be remiss if I didn't say, hey, this is the most restrictive option. And since last year, my counseling has significantly changed to, for the majority of my patients, really think about whether power of attorney, supportive decision-making agreement, or both could be more appropriate. Also, this is really expensive, so it helps that the others are not. And so as I go towards wrapping up my part of the talk, as I think about how we can practically support the process of transition. If any of you in the audience are pediatricians, and for all of you who have a pediatrician, I think that one of the roles of the pediatrician is to begin the conversation early. I personally schedule extra visits in the time of adolescence where I let the family know that my agenda is to talk about transition. Continue to assess a young adults and caregivers self-management skills, that being, do I know how to disagree with my provider? Do I know how to troubleshoot when obstacles arise? Do I know who to call when I need a refill or I need some DME, etc.? It's important for healthcare providers to educate families on available supports and resources, connecting families with community organizations that can offer support. really assist with the transition to adult specialists. And as I've mentioned, ensuring that information that is transferred to the adult provider is up to date and complete. Who can help? The IEP is such a powerful document. You can add goals around transition. You can have goals around health, sexual health, safety, independence. I think that we should really leverage this document when it comes to transition goals. The individualized person plan from the regional center can include goals and supports related to transition. If the individual is covered by CCS, your program may have a transition specialist that can help you with transition. I know that Alameda County had an incredible person and that has currently transitioned to a different position. But I know that that was an invaluable role. Gottransition.org is a really cool resource. They have questionnaires around transition readiness and a lot of other resources. Our clinic, Charlie's Clinic, has a website, and we have a section on teens and young adults that talks about a lot of these topics. And then the American Academy of Pediatrics has clinical reports for pediatricians and handouts for caregivers on their parent-facing website called healthychildren.org. This is gottransition.org and the QR code. And they have a transition readiness quiz that you can take if you're wondering where you are in your transition readiness. This is our website and the teens and young adults section. I'm in Alameda County. I love the Family Resource Navigators of Alameda County to pieces, same with the Care Parent Network of Contra Costa County. Most counties have a Family Resource Navigation organization that can support families. I know Special Needs in My City, for example, is one of them. There's many. By law, there needs to have, every area needs to have a PTI that offers information around special education. For many counties in our area, Disability Rights Education Defense Fund is that organization, and they're amazing, and they can think together with you about what's in your ITP. In Alameda County, we have the Developmental Disabilities Council and the annual transition fair, as well as Congreso Familiar for Spanish-speaking families. I wonder what is available in other counties, but again, the family or navigation organizations are good places to start for some of this. And I will take questions I think at the end after Alyssa's part, but you got this. You got this. It's gonna be okay, and there will be moments that might feel a little bit difficult, but you lean on the resources that you have, and you trust in your ability to navigate systems because you have done it for years already. And just like your young person has learned so many things, they can do this next transition successfully as well.
So Megan, should I just go ahead and start sharing?
Yes, go ahead and start sharing.
Okay.
Thank you.
I will do so. Gosh, that is a hard act to follow, Dr. Skenazy, but I will do my best. So here I am. I'm sitting here having pediatrician envy and realizing I wish I could clone you. So am I there? Everybody seeing my full screen? Yes?
Yes, we can see it.
Wonderful. Thank you. So you are at transition to adult medical care, a parent's perspective, as opposed to the pediatrician's perspective you just heard. And we're very glad that you decided to spend some time with us this afternoon. I am Alyssa DeFilippo with Parents Helping Parents, one of those parent training information centers that Dr. Spinazzi was just speaking about. We're also a family empowerment center and a family resource center. At the end of this presentation, I have some slides where you can find the PTI or FEC in your area. We provide consultations and in-person and online webinars, support groups. We have a very robust e-learning library. But what I do at Parents Helping Parents is manage a program called Connections California, Transition to Adulthood. And we have, again, a robust e-learning library, live webinars, about 90 to 100 a year, about transition to adulthood and adult resources. I feel as if my 26-year-old daughter is still experiencing her transition to adulthood. And as such, I'm learning right along with everyone else. And I'm here today because I was asked to speak about my personal story with Grace. And I've cleared that with her. So sharing our story with you today, she's fine with my doing so. But you'll be hearing my point of view, which in no way means to diminish her role or any of our young adults' roles, because it is, after all, their transition to adult healthcare. But it's essential that they're engaged in it, right? But the focus today is about parents. So I want to provide an overview about just one parent's perspective, mine, offer practical tips on how parents can approach this part of transition to adulthood, review some health insurance and public benefits and just a small amount of legal issues, because Dr. Spinazzi did a really good job in that, and share some resources. This presentation is resource rich. Instead of providing a bunch of resources, I just put all the links in the presentation so you can download the presentation and you'll have it all. And I want to touch a little bit on how to let go to let grow. So if you're a parent out there, or if you're not a parent and you're a professional, it's important to know that parents are sometimes just plain scared about everything to do with their kid's disability, especially when you consider your young adult's life after school. There's so much to do with transition to adulthood, the switching of systems of support, issues with public benefits, issues with legal aspects or decision-making aspects, Department of Rehabilitation connections, regional center services. If you don't have it, how do you become a regional center client when your youth is 16? Maybe there are some higher education technical schools, housing and other options. There's a lot with transition to adulthood. It can make your head swim and your hair fall out. And for me, one of the scarier pieces of all that is the healthcare transition. And please allow me to tell you why. Please meet Grace. She's a bit of an imp, no stranger to doctors, therapists, hospitals. She had a blood transfusion within hours of her birth, an MRI at 3 days old, 3 clubfoot surgeries, biofeedback therapy for intestinal muscle awareness. I'll go into that details if you really want to know. Several sleep studies, a tonsillectomy, physical, occupational, speech, vision therapies from a very young age, I think maybe about 6 months through her early 20s. She spent more time in clinics at UCSF than on playgrounds, and she always approached every adversity with pluck and determination. And she is so much more than her diagnosis, which is Prader-Willi syndrome. But let's face it, that is a defining part of her life, and it's a complex and challenging disorder. It includes abnormal growth and body composition, hypotonia, failure to thrive in the early years, but then at around 4 or 5 years old, she switches to an obsession around food. Eating it, talking about it, planning for it, and that insatiable hunger and the potential for obesity and all the medical issues that obesity can bring with it. So she's on a very low calorie, low fat diet. She calls it her healthy diet. And then there are learning differences, mild to moderate to severe intellectual disability, depending. So PWS is due to a dysfunction of a portion of the brain called the hypothalamus. It's a small endocrine organ at the base of the brain. And it controls lots of functioning like hunger and satiety, body temperature, pain, sleep-wake balance, fluid balance, emotional control, fertility. So it sounds like a lot, right? And it is. So add to that 26 years ago, and maybe even now, I'm not sure, most pediatricians have maybe read a bit about or heard a bit about Prader-Willi syndrome in medical school, and that's it. So you're put in the position as a parent of educating the doctors, the very professionals you're going to help you with this condition. So it hasn't been an easy road. And then you realize right about the time when all the other transition to adulthood concerns are rearing their heads, that we'll need to change all of her medical providers, her GP, her endocrinologist, her orthopedist, her physical therapist, her podiatrist, her gastroenterologist, her proctologist, Her psychopharmacologist is the only one who's been consistently with her, and thank goodness for him. So then you have to start the education cycle all over again. And like Dr. Spinazzi was saying, there isn't a list of adult providers who are just perfect for what you need. So we have switched over, and it hasn't always been easy, not always successful, but we are pretty stable right now. So we're just going to go through Grace's medical transition a little bit, where we were 2 years ago, where we are now, and where we're going. So about 2 years ago, we were coming out of COVID, right? And it was time to venture out to appointments, even though we weren't getting used to those telehealth visits, I got to say. So what do you do first? You ask for referrals from the specialists. Specialists were easier to find than the GPs. It's really hard to find a GP in our county, period, let alone someone who knows how to work with adults with developmental disabilities. So you ask other parents, right? Am I right? Parents helping parents. That's what we do. We let each other know when we find good resources. We had some handoffs and some first appointments happen during COVID and virtual meetings, which you can't always get a good sense if it's a right fit. And then I had to coordinate the transfer of all the medical files. And had I known what Dr. Spinazzi was saying about having a really good last note, because nobody's going to read all of them, maybe I wouldn't have spent all that time trying to get the really thick file that Grace had transferred over to her specialist and her GP. And some of that information was lost clearly because it was a really thick file. And then we started with those GOT transition surveys, which I have a little visual of on the next slide. And they're great. They just kind of tiptoe you into just the beginnings of transition. And then we also combed through the UCSF Office of Developmental Primary Care website looking for some resources, because that is also a great place to go. So this is just a visual of those GOT transition quizzes, and they're really simple. I think they're just 6 or 7 questions, and you can see I think it's the same questions for both the youth and the adult and the parent. Does your child know where their healthcare privacy changes at 18? And for the youth, do you know the phone number of your doctor? Is it in your own phone? So it's just a little bit of a tiptoe into how to ready yourself. These are some other resources that we have relied heavily on. PACER, which is the PTI in Minnesota, has a National Parent Center on Transition and Employment, and they offer a video series of young adults talking about taking charge of their own healthcare. So that's something that's real good for your youth to take a look at if you think they might be ready for it. The Family Toolkit, Pediatric to Adult Healthcare Transition from GOT Transition is wonderful. We're still working our way through that. There are a lot of good forms and questionnaires, but some Grace needs a lot of scaffolding with than others. And of course, the Office of Developmental Primary Care, I love it. It's a go-to for so many things. Their guide on sexuality and sexual health is wonderful. They have some tips for organizing visits, much like the ones Dr. Spinazzi shared from, I don't remember where, but I'm loving those resources. I'm going to add them to my lists. But there are tracking forms, both for patients and for providers and practitioners, which I find were really good, because those tips that Dr. Spinazzi was giving to practitioners, there are some forms that from ODPC that will follow them up. And then they have a really good supported healthcare transition making guide. I noted somebody in the Q&A was asking, so you can go and see it here. And then I also have other resources for you. So here is just a couple of examples of what, there we go, of what the forms on the Office of Developmental Primary Care, getting ready for my visit, following up for my visit. I'm not sure these are PDF fillable, but you could certainly print them. You could read them and fill them in, or you can have your youth fill them in, but it's kind of, again, a tracking mechanism. I actually also love their menstruation chart. I have to say, that was one of the things that first attracted me to their site. So I did mention the supported decision making, and I'm not going to go into this too much because, as I said, Dr. Spinazzi really covered it. But those limited conservatorships take away rights from the person, the adult with the developmental disability. The supported decision making, while it's not a legal document, it just helps to give that support so that folks can understand their options, make informed decisions without relinquishing their rights. And that durable power of attorney it is a wonderful thing that it exists. And the Advanced Healthcare Directive, also known as the Durable Power of Attorney for Healthcare, that's a legal document, and it allows the person to state in advance who they want to help them with their healthcare if you yourself become incapacitated and can't do it anymore. So suffice it to say, it's a personal decision for each family, and I am not expressing views of Family Voices or Parents Helping Parents, just my own family. And as Dr. Spinazzi said, 8 years ago, we weren't talking about supported decision-making all that much. So we do have a conservatorship for Grace. And I'm not sure. We felt that, and I'm not sure how I feel now. We might do supported decision-making with powers of attorneys, but we have the conservatorship. There is a certain level of comfort and having control over that. And this is not to say that Grace isn't consulted and would not be consulted and will not continue to be consulted about any of her medical issues. But what if we found ourselves in an emergency room and she was incapacitated? And what if it was a mental health issue? I carry those conservative papers in the glove compartment, and I have them on my phone just in case, because if it's a split-second decision and something needs to be made and it's a life or death situation, I feel a certain level of comfort that we can make them. But this is the important thing here. And this is most of the parents I know who have conservatorships and are conservators for their loved ones. We have a supported decision-making philosophy or mindset with a safety net of a conservatorship. So Grace is involved in all her decisions about her healthcare, and we'll talk about that in just a little bit. But one thing Grace doesn't know too much about, and we have to work on, is the health insurance. Now, the health insurance coverage, it could be an hour, 2 hour, 3 hours in and of itself. So the briefest of brief overviews here. Suffice to say that you can keep your 26-plus-year-old on your health insurance policy through your work. Please check with your employer or human resource department if this is possible. If your loved one gets SSI, they can usually automatically get Medi-Cal. If your loved one shifts from SSI to getting part of your SSDI, and it has that with that disabled adult child benefit, and if these are just a bunch of acronyms that nobody knows what I'm talking about, we have several videos at our Parents Helping Parents e-learning library, which can explain them more, and also our landing page has information and resources. Suffice to say, though, that after 2 years of having this disabled adult child benefit, that adult child, and I hate that term, but that adult can shift over to Medicare. And many people feel Medicare is a better policy than Medi-Cal. And you can also retain your Medi-Cal, and then you have this thing called Medi-Neti. So you can see this is a fairly complex thing, and just know that it's something out there, and it might be a good idea to get educated about it. Medi-Cal recipients can get Denti-Cal. It's called Smile, and you need to go to a Denti-Cal provider. And I think vision benefits are covered for those who have full scope Medi-Cal. But the adult could still be on the parents' plan for the dental and vision. But I would say to investigate that and follow up with it in writing, because like anything else, if it's not in writing, it wasn't said. Now, honestly, this world frustrates me. I admit to spending countless hours on the phone just recently trying to get a dental procedure, which is medically necessary for sleep apnea, covered. And I'm kind of out of practice. I used to pride myself on being a health insurance bulldog, but I'm weary now. So we'll see what happens with that. And I wonder whether I'll ever really turn that over to Grace. I don't know. She's very tenacious and pretty darn persuasive when she gets going. So who knows? We need to have high expectations, right? She is able to research doctors. She has made medical decisions on her own, which brings us to where we are now. Since we started this adventure a couple of years ago, Grace is going to several of her medical appointments with her self-determination program staff, not with me, her annual, her ear, nose, and throat, her podiatrist, her optometrist. She's making some of her own appointments, and she's working on putting them in her calendar and making sure that she keeps those appointments. Dr. Spinazzi mentioned that laminated card that has the medications, the dosages, the frequencies. It's always asked for at any doctor's visit, right? She does manage her own prescriptions, of which she has many, filling out her own prescriptions, keeping on top when to reorder. asking the doctor when it needs to be ordered, sending texts. She's working on explaining her disability in 3 sentences or less because, as aforementioned, not a lot of providers know a whole lot about Prader-Willi syndrome. So it's important for her to be able to explain PWS to a medical provider. And, you know, the latest, it was Grace's decision not to have jaw surgery to address sleep apnea. I was the one who did the research for alternatives, which led us to an orthodontist who would do a palatal expander and clean up the alignment of her jaws so she can ready her mouth for potential oral appliance that addresses the sleep apnea. And Grace actually keeps a list of questions on her phone to ask providers. And when we got back from the oral surgery, and this was just last week, she declared, I'm going to be a grown-up and I'm going to call the orthodontist office and ask about using a water pick. So she did. She got the okay. She researched water picks and then she bought one with her own money. So sometimes things just work out. The one thing I want to mention before I end is the one-page profile for medical appointments. Now, if you don't know what a one-page profile is, I think it came out of the person-centered planning, a person-driven planning world. And it's a one-page sheet that lists at least 3 to 4 sections. What people like and admire about me, describing the person's strengths and talents, what's important to me, what are the things that are really important to a person, what's important for me, and those are usually around the health and safety concerns, and also how best to support me. So this one-page healthcare profile, I have an article written by a woman who's a parent and also a person-centered thinker. And then I have the example of the one-page medical profile she made for her daughter. And then this actually is a PDF fillable of this. So you can go to the National Center on Advanced Person-Centered Practices and Systems and get this as a PDF fillable. And you can put pretty much any information you want on this at all that you want the medical provider to know. And you can hand it to the nurse when they come in, you know, the nurse comes and does the blood pressure or the physician's assistant. You can hand that to them. You can hand it to the doctor, whatever it is that information you might want or your adult might want or your youth might want the doctor to know could be on that sheet. Now, the teacher who I've taken some person-centered planning classes and from is, her name is Trudy Grable. Her information is also in the resources. Her daughter's medical one-page profile talks about how her daughter likes to have an ace bandage wrap whenever she leaves any medical appointment, makes her feel comfortable. So that happens. Every medical appointment that her daughter goes to, she leaves with an ace bandage wrap, and that makes her feel good about herself. And that's really, really all we want for any of them, right? Us too. So where are we going from here? Well, we'd love to keep increasing Grace's responsibility for her healthcare as much as we can. Do we ever envision a time when I won't be involved? Probably not, except when I'm gone. But we'll keep seeing what she can do and can't do, because that will help her circle of support, both the paid and the unpaid folks. And, you know, that's what we're looking into by writing a person-centered support plan now to give that information over to folks who can help her. But the more she can do for herself, the less they'll have to do. But also they can give her scaffolding with her healthcare. But again, the more she can do, the better she'll feel about herself. So what have we learned through this whole process? Well, to think big, to have high expectations. Everyone progresses to the highest level they are able to achieve if there is a clear expectation by those who matter to them that they do so. I'm going to say that again. Everyone progresses to the highest level they are able to achieve if there is a clear expectation by those who matter that they should do so. Self-advocacy is key. But how can someone get the help they need if they don't know the help they need and they don't know how to ask for it? So, you know, in summation, let me just say that it feels good to let go and let grow. And that is a phrase I got from Trudy Grable. And I have to say, it was scary at first. When Grace ventured out into her own doctor's appointment, the first one, I was sitting by the phone. I was sure I was going to get a phone call to do some kind of consulting or answer a question or do something, but nothing. Radio silent. She handled it all by herself and she did a great job. And if you would have told me 10 years ago she'd be doing that, I'm not sure I would have believed you. But there you have it. So as promised, resource-rich presentation, lots of resources already in the presentation. Here are a bunch more. that we have a video actually on sexuality and special needs, Let's Talk Sex. That's on the PHP website. Lots about those navigating entitlements. This is the one I mentioned before, SSI Medicare. Here's Trudy Grable's site. There's the Learning Community site. Here's a pediatric to adult healthcare packet of information, we call it, but it's really not a packet. It's a couple of pages with lots of links to resources. Here are all the PTIs in the state of California. Here's how to find your FEC. This map is not updated yet. And we're ready for questions. Thank you so much.
Thank you so much to our panelists. We do have some time for some question and answer. If folks have questions, please put them in the Q&A chat feature. I do see a question there. Looks like potentially for Alyssa, if you want to answer that.
Is that the adult providers? I have had family members tell me adult physicians totally ignored the conservatorship papers they had. What is your experience? What have you heard about adult care providers accepting and dealing with relating supported decision-making? I think that's more of a question for the esteemed Dr. Spinazzi.
I mean, it's not allowed. It's illegal.
Yeah, I mean, I've never had any problem with it.
Yeah, so there's a system of complaints and grievances that are available to call out this kind of behavior, and you know, it might be reaching out to an advocate organization. It might need to be trying to speak to that person's supervisor, but the law is on your side, and if there's any confusion, then appealing to the systems that are in place to keep us all honest is the way to go.
Yeah, I see a bunch of Dr. Spinazzi has given some very good answers in some of these questions. I really do. I want you as I'm going to have another kid so you can be its pediatrician.
Sounds good to me.
So I'm not sure. No more questions. We have wowed them into
Yeah.
submission.
Any more questions? Please feel free to put them in the Q&A. Yes, lots of requests for the slides. We will definitely make sure that that is sent to all of the participants.
That's wonderful. And somebody's saying that they feel inspired and a little less nervous. And that's wonderful. That's one of the reasons Parents Helping Parents created Connections California, is to help with the stress, because the sooner you start thinking about these things, the more you'll start getting informed. And the more, like when your youth is 16 and suddenly you see this ITP in your IEP and you don't even know what it is. I mean, that's very, very scary. And then you have the SSI and the IHSS and the medical insurance. It's a lot. It's a lot. We even have something on, we wrote a training called Cradle to Career, which is not a term we thought up. I know I've heard it from Kristen Wright and a bunch of other folks, but we do it for that 0 to 5, because we want to first acknowledge, yeah, you know, now you got this kid and he's got a disability and this is a new world, and yeah, you're in Denmark, not Italy, whatever that poem was. But understand that, you know, we have the 5 protective factors and we want to keep everybody in our family safe, but we also want to start thinking about person-centered thinking, person-centered planning, and know that this little life you have can grow to be a robust self-advocate. And as a robust self-advocate, there are skills you could be teaching them when they're 2. You know, you want an apple or an orange. You know, I mean, I'm fond of saying my daughter used to leave the house in like a pink polka dot shirt and striped pants and a, you know, a pink sequence vest. And I was like, you look great. And, you know, and she did. And that was her style. But to also understand, you can teach those college and career readiness skills in preschool. In fact, we have a woman coming to talk about that in the fall as part of our Connections California. So tune into that. You know, the Connections California link is in my presentation, so check it out. We really believe that information is the best thing that you can possibly have to alleviate your stress.
So thank yous for a wonderful presentation. Great. So we'll go ahead and end the session. After the session is ended, you should see the page for our event lobby, and you can click at 1:30 to join today's closing session. Thank you everybody for attending. Thank you so much for the presentation and wonderful information. I hope everyone has a great rest of the day.
And you got this.
Love it.
Bye.
Bye-bye.